Buenos días. Esta conversación será en inglés. Si prefieren escucharla en español, pueden hacerlo seleccionando este idioma usando el botón de interpretación abajo en su Zoom. Good morning, and welcome to this webinar of the Panorama of Aging and Long-Term Care, organized by the Inter-American Development Bank with support from the French Development Agency. I am Marco Stampini from the Social Protection and Health Division of the IDB, and I will be moderating this webinar. Today's topic is cash and counseling, family-directed long-term care plans. Cash and counseling provides beneficiaries with a budget for long-term care and allows them the freedom to self-direct this budget, to purchase the services that they most need, and also to select the provider of their choosing. May this be a professional, a friend, or a family member. We are honored to host Dr. Pamela Doty, who will share her experience with the cash and counseling demonstration and why this is relevant for policy making in Latin America and the Caribbean. Pamela has an extensive knowledge on this topic. She is Senior Policy Analyst at the United States Department of Health and Human Services, where she focuses on long-term services and supports financing. She has served on numerous task force groups and commissions related to long-term care. For example, the Pepper Commission as White House appointee, and as well as Hillary Clinton's Healthcare Task Force in the 1990s. We will have a presentation of approximately 35 minutes, followed by questions and answers. We invite you to ask your question in the language of your choosing using the Q&A button in Zoom. Your cameras and microphones are not active. Thanks a lot, Pamela, for joining us today. The floor is yours.
I want to thank the Inter-American Development Bank for inviting me, and particularly I want to thank Marco Stampini and Beatrice Fabian. I'm going to be focusing primarily on, I was having trouble with the slides. All right. Okay, I'm going to be talking about cash and counseling, which we're calling presupuestos con consejos in Spanish. But first I have to talk about where it fits into our long-term care system of public funding, which in the US is primarily via Medicaid, which is a means-tested federal, state financed and administered program that began in 1965. It covers people of all ages with all different types of physical and mental disabilities who need long-term care. For the first 20 years, 90% of the funding went towards institutional care. Spending on home and community-based services exceeded 50% only in 2013. It says here we're at 57% now, but I just checked in the last 2 days and we're now at 59%. Latin American countries who are planning to invest in public long-term care systems currently have few nursing homes, which gives them the opportunity to prioritize home and community-based services from the get-go. There are various alternative modes of home and community-based services delivery. Two basic ones. One is formally organized, professionally managed services, which typically involve a service plan written by a case manager, and services delivered by formal organizations, for example, aid services from home care agencies that employ and supervise those aides. The alternative is self and family directed services. This is an optional alternative, which offers individuals and families more choice and control over the services they receive and their service providers. Typically, paid aides are individuals who may be persons they already know and trust, including family, friends, or neighbors. About 1.2 million Medicaid home and community-based service users self-direct their services. That's about 1 in 4 of those who are receiving home and community-based services. Research has found that self-direction correlates with what we call rebalancing or reorientation of spending away from institutions towards home and community-based services, and that it correlates with lower rates of transition from the community to institutional care. There are also 2 different types of self and family-directed modes of service delivery: employer authority and budget authority. Employer authority limits beneficiary family choice and control to hiring, firing, and supervising individual aides of their choosing. The number of hours and hourly wage rates is set by the program. This model has been around for a long time. It started in California in 1974 due to very strong advocacy by the independent living movement of disability rights advocates. The leaders of that movement were people who were polio survivors, many of whom were very significantly disabled, but with the services that they could get, they could go on and live fulfilling lives and even have wonderful professional careers. Budget authority self-direction provides beneficiaries and families with a flexible budget. This is a monetary allowance, which they can decide how to spend within certain rules and regulations. It began as the cash and counseling demonstration and evaluation of a social experiment in 1998. Budget holders may negotiate hours and hourly wage rates with their aides, so long as they comply with labor law. So they have to pay at least minimum wage. For example, the budget may also be used to purchase other goods and services, some of which are rather unorthodox insofar as they wouldn't be available in the formal services model, so long as these address disability-related needs rather than sort of basic living expenses. The cash and counseling experimental demonstration was sponsored by the Robert Wood Johnson Foundation, which is a large philanthropy in the US, and co-sponsored by my office in the Department of Health and Human Services. It took place in 3 states, and it was launched in those 3 states between 1998 and 2000. And the final report with all the findings came out in 2005. Then it was followed by replication grants to 12 more states. This program was known as Cash and Counseling. Despite being a catchy and appealing name, that name is somewhat misleading because program participants do not literally receive cash in the form of unrestricted direct payments. So this is why I actually prefer the Spanish translation of presupuestos y consejos, because it more accurately captures the concept. We found that the individual states gave their programs state-specific names. None of them used cash and counseling for their programs. So independent choices in Arkansas, personal preference in New Jersey. My personal favorite is New Mexico's Mivia, which they chose to honor their Hispanic heritage, even though they know that that's bad Spanish. State officials worried that the name cash and counseling would cause political problems with state legislatures who were suspicious that poor people receiving unregulated cash payments would misuse them for inappropriate, possibly fraudulent or even illegal purposes, drugs and so forth. They also believe that public programs should be accountable to taxpayers for how the monies were spent. We don't do, unlike many European countries, such as Italy, Austria, Germany, Spain, and the United States, we just don't do tax-free, unrestricted payments, at least not for home care. So no checks, no direct deposit to beneficiaries' personal bank accounts. Beneficiaries decide how to spend their funds within some restrictions, but all financial transactions occur by an accounting service, which bureaucratically we call the Financial Management Services Entity or Fiscal Intermediary. This accounting service is paid for by the public program. and it's a key feature of the counseling component of cash and counseling. The accounting service carries out financial transactions according to the beneficiary's spending plan. Most importantly, the service acts as his or her payroll agent to pay their individual aides and ensure compliance with tax, labor, and immigration laws. The employer authority model is dominant, but the budget authority model is gaining. It's dominant because it's older, having begun in California in 1974, and because California's in-home supportive services program is by far the largest home and community-based services program in the US, with a monthly caseload of 550,000, 95% of whom self-direct their aid service. After California pioneered this model, it spread to other states over the next 20, 25 years: Michigan, Wisconsin, Washington, Oregon, Massachusetts, Pennsylvania, New York, some examples. And then in the late 1990s, we decided to experiment with a more expansive budget authority cash and counseling model. After positive random control trial evaluation findings, it became regularly available in Medicaid via regulation starting in 2003, and further expanded in legislation enacted in 2005 and 2009. I'll just add here, this was a really good example of how policymakers were impressed with the random control trial evaluation and the findings, and they really paid attention to that. Pre-pandemic, a national inventory estimated 1.2 million self-directing Medicaid HCBS recipients, still nearly half of them in California. The early results from a new inventory indicate continuing growth, especially for the budget authority model. For example, in New Jersey, the take-up of personal preference in New Jersey, the budget authority model, went from 27% in 2017 to 42% as of 2021. Whoop. Okay. California's in-home supportive services program pioneered the employment of family caregivers in the early 1970s. In California, from the beginning, they included spouses and parents of minor children. They could be paid too. Initially, not all states that adopted self-directed services options allowed hiring family members. New York didn't come on board with this until 2012, but now every state permits paying family, but only 12 will allow payments to spouses. Family, like non-relatives, must be legally employed in compliance with tax, labor, and immigration laws. The policy purpose is to allow family caregivers, if preferred, while also enabling those family caregivers to earn income they need and to otherwise benefit from participation in the paid labor force. Research indicates that paid aides who are family members provide better quality care on average compared to non-relatives. The prevalence of family as paid aides varies by state and within states by programs targeting different populations, age groups such as elderly, long-term care conditions such as intellectual developmental disabilities, et cetera. In California, in home supportive services programs, 70% of paid aides are relatives, of whom more than half share a household with the service recipient. And when they're sharing a household, that tends to be the most disabled people. Hiring relatives is especially popular among first and second generation Latino and Asian families, and also among the elderly who prefer to employ adult children. For example, across the 3 states in the cash counseling demonstration, between 47 and 59% of older people in the demonstration hired their adult children. Hiring family is least popular among physically disabled adults under age 65. It's an autonomy issue for them. They often want to have more of a professional relationship. Parents are often employed to care for adult children with intellectual disabilities. They tend to be people who have high needs. So oftentimes when a family member is hired, there are also unrelated caregivers, at least one or two more. Some advocates have expressed some concern that parents' long-term dependency on caregiving income may prevent children with intellectual developmental disabilities from maximizing their independence, from moving outside the family home, getting a job, something like that. You know, it's hard to say because oftentimes it's very difficult for people with intellectual developmental disabilities to truly become independent. They need a lot of support. What about training to professionalize home care workers? This is an aim that some advocates think that home care workers should be professionalized. The research indicates that HCBS recipients, or home and community-based services recipients, define quality of aid care primarily in terms of relationship characteristics, such as compatibility, trustworthiness, attentiveness, respect, reliability, continuity. They're less concerned about technical competency in performing personal care tasks, which doing the task is typically the focus of formal training. Agency aides do receive more formal training, and I think it's appropriate that they would get a standardized type of training because they're going to see a lot of different clients. They're going to be shifted around a great deal. So they have to be prepared for a lot of different kinds of people with different needs. But individually hired aides, family and non-relatives, are more likely to be with somebody for a long time and be there, not have other people that they're working for, not more than one more person, but usually just one. And they're more likely to accompany their service recipients to doctor visits and be given information and instruction by doctors and nurses. Whereas you find the agency aides, they don't go in the exam room, they sit in the waiting room and wait. But the individual aides, they go into the exam room and interact. Also, state nurse practice acts allow them to be trained to perform routine skilled nursing tasks. This is particularly the case for family members. There's an exemption in every nurse practice act that allows a nurse to train a family member to do this. And a number of state nurse practice acts have been amended to grant the same exemption to individual and family hired aides. But there's always the other option of what is called nurse delegation. And again, that is far more common when people are hiring individual aides. The agencies are not, they're very wary of allowing their aides to perform any kind of paramedical tasks. And they often get some pushback from their nurses about training aides. They have liability concerns. The other thing is that self-direction allows for customized training, which is likely to be more useful and less costly than a one-size-fits-all standardized training. So when people hire someone, knowing what the background of that person is, knowing what the individual needs, they can ask themselves, well, is there any kind of special training that the aide should have? And counselors can help with this to identify such needs, along with funding and sources where they can, places to get the training. Who's eligible for self-directed services? With few exceptions, anyone eligible for home and community services can choose to self-direct his or her services under either employer or budget authority options. However, home and community-based services eligible individuals who are cognitively impaired must have a designated representative to assist them or to act as their surrogate decision makers. Others may choose to name a representative, even if they are not required to do so. They just want that. And we see a lot of that, especially among older people. Representatives are typically close family or friends. They may not be paid for serving as representatives, and they may not be hired as paid aides either, because they're going to be the ones who are helping to supervise. They might be signing in the timesheets of the paid aides, so they can't be paid themselves. Virtually all program participants with intellectual developmental disabilities have representatives. That makes sense. And a majority of older Americans have representatives, either because they have Alzheimer's or dementia, or because they just feel more comfortable naming someone to be their helper. And we find that a minority of physically disabled adults under age 65 have representatives, because most of them do not have any cognitive impairments. Needs assessment and benefit determinations precede being given the option to choose self-direction. So step one is someone applies to the program, they receive an in-home needs assessment to determine eligibility and coverage. The assessor who conducts the needs assessment, who might be called a case manager, administers a standardized needs assessment instrument, and scoring determines the benefit, which might be either a certain number of authorized hours of aid service maximum per month, or a monetary limit on spending or range of HCBS. And if it's a monetary limit, then it's going to apply both to the formal services and to the self-directed services, although it may be a little bit less for the self-directed services, because people that use formal services, the formal services providers have a lot of overhead expenses. So that tends to be a more expensive model. So there may be a slight discount. Even when state benefits are generous, it's important to recognize that paid care rarely covers more than 20 or 25% of the hours of help with daily living tasks that beneficiaries receive. So most people, they're going to still need unpaid help from family members. And this is one of the rationales for saying, well, since the family members are going to be still doing a lot, they should have a lot of say in, which hours are covered and so forth. Those who choose traditional formal supports are assigned or may be allowed to choose a case manager, who may be the original needs assessor, but more often is someone different. Self-directing beneficiaries exercising budget authority get support from counselors. So how does case management differ from counseling? Case management has historically followed a medical model. Case managers, usually they are nurses or social workers, assess functional assistance needs and develop a service plan to, in accordance with the needs that were assessed. Implicitly, there's an analogy being made to a physician diagnosing a patient and prescribing a treatment plan. However, identifying functional assistance needs, such as the need for help with bathing, dressing, feeding, toileting, does not require medical knowledge necessary to diagnose illness. So the analogy is already weak on that line. Also, Medicaid does not allow home and community-based services case managers the broad discretionary authority that's given to physicians. They can only authorize the services that are defined and listed on each state program's menu of covered services. And often specific services are subject to coverage limits. So they just don't have all that much power. Counseling is a social model which recognizes that the purpose of HCBS is to help people with functional limitations live as normally as possible according to their perceived needs, preferences, and priorities. Sometimes the advocates use the slogan, "I want a life, not a care plan." And just as an example, it's not enough to just have somebody who will help you get in and out of bed or to take a bath, but you want them to do those things on your schedule, not a home care agency's schedule or convenience. So this is just an example of what the difference can be when people want us, want to direct their own plan so that it supports the way they want to live their lives. Several years before I became the project officer for Cash and Counseling, I had a really eye-opening experience. I accompanied a case manager on a home visit to two sisters aged 70. They were older than 70, who were family caregivers for their 55-year-old niece, who was severely disabled from birth due to cerebral palsy. I used to love to do these home visits from time to time. We called it reality therapy for federal officials. And the niece, Patty, could not walk or talk, but was very friendly and clearly loved socializing. The sisters complained to me that past case managers had tried to get them to accept respite services, to get out of the house, do what they wanted to do, and leave Patty with a sitter. They felt condescended to by this kind of advice, and they said they didn't want or need respite because Patty was no burden to them. Their lives revolved around the Lions Club. This is a fraternal order that emphasizes service to the community, and that sponsors social events and raises money for good causes. The sisters had a van in which they took Patty in her geriatric chair to all the club meetings and events. And if it was a dance, the men would take Patty in their arms and dance around with her, which she absolutely loved. The sisters also took Patty on trips to visit family in California. However, the sisters had difficulty getting Patty's geriatric chair into and out of the van. A son living nearby had helped until a health problem prevented his continuing to do so. So the elderly sisters were risking injury to themselves by having to push this Jerry chair and lift it into and out of the van. They needed a van lift, but they couldn't afford one. They asked me, why won't Medicaid give us the money they're so willing to spend on respite care that we don't want so we can buy the van lift? They had actually convinced their current case manager, the one who was with us on this home visit, who had kind of mentally shifted into the counseling mode and had tried to advocate with the state that this would save money on medical transportation for Patty in the longer run, because Medicaid had to pay for ambulances to take her long distances to medical and dental appointments. But the case manager was unsuccessful because this and other handicap vehicle modifications were not on the covered HCBS menu. If they'd had a cash and counseling budget, they could have used some of those monies or the monies to buy a van lift. And that really got me thinking about, this kind of more flexibility in what people could be allowed to have, and listening more to what they said they wanted. What do counselors do to support self-directing HCBS users and families? Well, they often help with paperwork to employ individual aides, which initially can be very daunting in this country. They also check the math and spending plans to ensure that people are not going over their allotted amount. I should mention, you can carry money over at least for a year, from month to month. So you don't have to use everything that you're allotted every month. You can save up for some expensive things. The counselors coach service users and families in self-direction skills. For example, how to interview and screen applicants for aid jobs, how to write an employment contract and make their expectations clear. But counselors may not become directly involved in hiring and firing aides. They also advocate with the state if necessary. Make the case for non-traditional goods and services that address legitimate needs for functional assistance and are cost efficient and effective. For example, one cash and counseling participant in Arkansas was able to buy a stackable washer dryer for his apartment so that his aide didn't have to take the laundry take his laundry to an outside laundromat, which obviously in an outside laundromat, the aide would have to sit there and just wait for the machines to go through, couldn't do other work. So this was, very efficient. The counselors can help brainstorm creative, if sometimes unorthodox, solutions that rely on neighborhood or community resources rather than formal HCBS providers. Self-direction has several advantages, but it's not necessarily right for everyone. Self-directing beneficiaries may find the added responsibilities of decision-making onerous. Recruiting and managing individual aides may be especially challenging if they do not have family, friends, or neighbors available to hire or whom they wish to employ. Worker registries are among the support services that programs can provide, and some do, to help self-directing program participants identify non-relatives who are interested in working directly for those in need of aid services and their families, instead of becoming home care agency employees. And I would add here that we think that self-direction has expanded the labor pool, because there are a lot of people who really don't want to work for an agency, or they want to work for a friend or a relative, but they don't want to work for strangers. And we have a worker shortage in this country. I don't know if that would be true necessarily in Latin America, but it is definitely true here that we don't have enough workers. Until recently, these registries were telephonic, but increasingly they're going online. Advantages of self-direction: better outcomes. Substantial research literature resulted from the cash and counseling demonstration that included a random control trial evaluation, as well as from other studies of self-direction in California and in other states, comparing outcomes for these programs to the outcomes when people are receiving formally organized, professionally managed services. On all dimensions in the cash and counseling evaluation, in particular, service user satisfaction with services, quality of life, reports of unmet need for functional assistance, adverse outcomes of poor care, such as bed sores, reported stress and burden on family caregivers, cost of care. The outcomes for self-directing program participants were often better and never worse than for the formally organized, professionally managed services. Moreover, reported job satisfaction with pay and working conditions was greater for the aides hired directly by self-directing service users compared to agency employed aides. Honoring preferences for family caregiving. What's the rationale for requiring family caregivers who want to provide home care to their relatives but need the income from employment to take jobs outside the home, while others, usually strangers, are paid to do the job they would have preferred, especially if hourly wages for alternative employment available to them outside the home is the same or lower? We also find there can be a problem that some people, service recipients, they really reject strangers. It tends to be a problem with people with dementia and sometimes the people with intellectual developmental disabilities as well. US research indicates that most unpaid family caregivers who become paid aides continue to provide additional hours of unpaid care. For non-relatives employed as paid aides to be asked or even volunteer to work additional unpaid hours violates the Fair Labor Standards Act, but the FLSA, Department of Labor, recognizes that that should not apply to family caregivers. They should be allowed to give additional help. And research indicates that when unpaid family caregivers reduce the total time they devote to caregiving, both when they become paid aides or when others are hired, the decrease is small. It's consistent with a respite effect, like 6 or 8 hours a week, perhaps. Administrative costs are lower when self-directing program participants recruit and supervise individual aides. Home care agency overhead typically accounts for 40 to 60% of hourly rates, whereas the accounting service and counseling costs about 10 or 20%. Savings can be used by government to serve more individuals and allow for more generous benefits, including better pay and fringe benefits for home care workers for the same total cost that would otherwise be required to pay for formally organized, professionally managed home and community-based services. Continuity of care is another advantage. There's considerably less turnover among aides that are hired directly by individuals and families. Annual turnover among agency workers in the US averages 60%. Agency aides are often absent or quit unexpectedly, and agencies routinely reassign aides to other clients for convenience of scheduling and to minimize travel time between clients. So here's an example of why this can be a problem. One cash and counseling program family member told researchers that when her mother previously received agency services, the agency insisted that, economically speaking, they had to do it in 4-hour blocks. So you could have 8 to 12 or 12 to 4 in the afternoon. And they wanted the worker to get the mother up in the morning and dressed and all of that. But the mother with dementia resisted getting out of bed before 10 a.m., becoming physically and verbally combative if she was forced to do that. To avoid this, the agency worker sat on the couch watching TV for 2 hours until the mother was ready to get up. When they joined cash and counseling, they directly hired an ex-agency aide they liked who was happy to come on their schedule. Another advantage of self-direction is that having sufficient providers immediately to meet demand. When public funding for HCBS first becomes available, there are typically few formal service providers. It can easily take several years for a robust network of formal service providers to emerge. As a result, if eligible individuals must get aid services from home care agencies, there are likely to be lengthy waiting lists. Meanwhile, unpaid experienced family caregivers already exist and likely could use the income from paid employment. It's also easier to establish the accounting services that self-directed services programs require. Most states contract with only one or a limited number, whereas home care agents, formal agencies, they're very localized, and you usually will have many hundreds in a state. The challenge of recruiting and training local counselors is about the same, no greater than that of recruiting adequate numbers of case managers. So this is my contact information. And then I've got some references and additional resources to share that you can have. And thank you very much for listening to my presentation.
Thanks a lot, Pamela, for this presentation. We think that this model has lots of potential for Latin America and the Caribbean. And I would like to highlight a difference relative to a solution that is sometimes discussed to recognize the work of family caregivers, which is a cash transfer to the family caregiver. The two differences are that first, the cash and counseling gives the ownership and the control over which services to purchase to the person with a disability or with functional dependence. It's not a benefit to the caregiver. And second, if the family caregiver is hired, it is done so with a work contract, which implies also enrollment, for example, in Social Security. So these are two big differences that it's important to highlight. And let me jump straight into the questions and answers. So the first question is about training.
Mm-hmm.
What type of training is typically required for the counselors and also for the hired family caregivers? Are there requirements? Is it voluntary? How many hours? How it's done?
Every state has its own way of training the counselors. There's a lot of material about that available on the website of Applied Self-Direction, which was one of the things I listed. It's mostly what's important is that they have to change their mindset. And we did run into some problems when some of the case managers, when they had somebody that wanted to self-direct and they had to shift into counseling mode, it was hard for them. Whereas some of them said, oh, I always would have, I wanted to work this way from the beginning. And interestingly, we're seeing a kind of convergence of those models because over time, a CMS, the Centers for Medicare and Medicaid, they've written regulations saying there has to be what they call a person-centered planning process for every HCBS recipient. And they stress the fact that it has to be led by the recipient or their family, and that other people that are in the support circle of the HCBS recipient should also participate in the planning process. So it's getting more and more that even a case manager is not supposed to be, I know what's right for you. I'm the professional here. You need respite, for example, which some people do want respite, but others, my example showed, they don't. So it's a mind shift, and for some people it's hard, for some people it's not. So sometimes we like to have them specialize and not try to change hats. As for the training for the workers, the training is pretty minimum for agency workers. Never, I mean, in the most demanding state is Washington State, and they require 80 hours. So you're talking 2 weeks. It's not a whole lot. And there have been issues with the training. Washington State they have routinely translated the training and the certification exam into 8 languages, and for less commonly used languages, they set up personalized approaches. And sometimes some of the people it's been a problem that they actually, there's some attrition that goes on if they're forced to go through the training, especially for people born in other countries where they had maybe bad experiences with schooling as children. They're kind of afraid of classroom schools and tests and things. It's really not necessarily that they don't know what they're doing or they can't do the work. But in any event, sometimes the training can be an entry barrier. This is another problem. So this is, again, why we sort of think that with self-direction, this idea of doing a customized training makes a whole lot more sense.
Thank you. Patricia asks if there is any mechanism or provision to check or influence the quality of the services provided in the homes. We know that measurement of quality of these services is not straightforward because it's in a private setting. How is quality handled in cash and counseling?
Well, the counselor, one of their jobs is to pay a certain amount of attention and to make sure that, they have to do something if they suspect any abuse or neglect or anything like that. And every once in a while, you find that they will change. They will tell somebody, well, we think you need a different representative because we don't think the representative you have is serving you well. These are pretty few and far between. This doesn't happen a whole lot. But the other issue is, what is quality? If you're in a medical mindset, you think of it as like competency in performing procedures. Well, what is a procedure in home care? Like giving somebody a bath, for example. There are good techniques, and I'm not saying it's not worthwhile learning those techniques, but sometimes different people have different ways in which they should be bathed because of particular conditions they have, because of pain or issues like that. And, there are things. One thing that I'm particularly concerned about, and we're doing a lot of work on now, is we want to get more assistive technologies into the home, because there's a lot of lifting and physical strain involved, both for the unpaid caregivers and the paid caregivers. And they're there by themselves. And the Center for Disease Control, the studies they've done suggest that it's really not a good idea to lift more than 30 pounds of dead weight. And that repetitive lifting, a lot of home care workers end up with musculoskeletal injuries. And this is a problem we have to address. This is one reason why we have a high turnover. So ways to make it less physically potentially injurious to the workers is a big focus of some of our research now. Because you find sometimes people say, well, you've got to be given training in proper lifting techniques. The thing of it is that the lifting techniques, there aren't any lifting techniques that beyond this 30 pounds is going to keep you safe.
Thank you. One of the points of cash and counseling is that it's about a benefit that is for persons that are in Medicaid, which, to explain to our audience, it means that it's below the poverty line.
Yes.
Now, is there anything of this model that has become relevant also for people that are above the poverty line, that are not in Medicaid, or it's a program that is totally restricted to persons that are in Medicaid?
Well, the public funding is restricted pretty much. Some states have supplemental programs that have a little bit of a more generous means test, but basically, interestingly enough, if you have private long-term care insurance, the private long-term care insurance companies will let you hire individual providers. I know my parents had private long-term care insurance, and I helped them find individual providers who were great. They weren't relatives. And I've had other experience with close family members. Just last year, I really needed somebody to help with a relative who was in hospice care. And believe it or not, the hospice agency in Washington, D.C., the metro area, they didn't have any Spanish-speaking nurses or aides. And so I particularly needed to find somebody, and I was able to go on an online registry called care.com, and within an hour, someone had answered my ad, and she was perfect.
Fernando asks, in Uruguay, the long-term care system aims to promote gender equality by freeing women from family care. From a gender perspective, have you encountered resistance to the cash and counseling program in the United States? How, if at all, have you overcome this resistance?
Could you just repeat you said something about freeing women from?
Yes, one of the motivations of the development of care systems in Latin America is to try to free the time of family caregivers.
Okay, well, the reality of home care is that you're not going to be able to stay at home unless you have at least some unpaid help to supplement whatever the public program, even when the benefits are generous. So the idea that you're going to completely free the family, probably not. you know, the best you can hope for is that they'll be able to schedule, and maybe they'll be able to have a different job outside the home for some hours while continuing to provide unpaid care, because it's the hours of help that people tend to need when they're not in a nursing, well, they need a lot of help in the nursing home too, but if they're staying at home, they need a lot of one-on-one assistance. And much of it is, especially at higher disability levels, unscheduled assistance. So somebody's got to be around or on call. And I've done a lot of studying of what other countries have done, and it's very interesting. In Scandinavia and in the Netherlands, they originally, when they started out, they had this fantasy, I will call it, that they were going to be able to free family members from having to provide care. They were thinking of it as like, well, you know, we have Social Security pension benefits, and that has meant that adult children don't have to financially support their parents. And they somehow thought that they could develop a formal service system that would do the same thing. And they found out they couldn't. And so over time, they've had to recognize that and change their systems and kind of revalidate the importance of family caregiving as a partner with whatever formal services are being provided. And the Netherlands is really a very good example of that, because unfortunately, they had to actually cut back some of their publicly funded services because it was just taking too much of the GDP.
Lisette asks, if you were the advisor to a government with limited resources in terms of budget and trained human resources that wants to implement a pilot for home-based services like cash and counseling, what would be your main recommendations? And let me build on Lisette's question and ask one that I was preparing. What would be the first things that you need to do to start doing cash and counseling? What is the administrative machine that is needed, the institutional development that you need to do to start? Where would you start from?
Well, obviously, you've got to get all your policymakers on board with the concept and understanding it and understanding what the value could be. But I think one of its biggest advantages is the cost effectiveness. As I said, the home care agencies have very high overhead. Interestingly enough, I think Medicaid, they regulate it to some degree. So in the private duty agencies that are serving private pay clients, 60% overhead is not unusual. And just to give you, I mean, this is not a Medicaid example, but when my parents needed care, they started out using an agency, and they loved the care, the aid that they had. They were paying $18 an hour. This was in 2009. And Marcia, the aide, was getting $8 with no benefits beyond the $8 an hour. And I was just horrified by that. And I said, no, let's hire an individual aide. And with the money you're spending on the agency, you can give this person a decent hourly wage. And so that's what they ended up doing. And towards the end of her life, my mother was in hospice, and she needed 24/7 care for the last 6 weeks of her life. And we had one lead aide who was in charge of scheduling all the others, and we upped her pay, and it was a great experience. I think it was a great experience for her too, because she'd never been given that level of responsibility before. And it did a lot for her self-confidence.
Blanche asks, could you elaborate on the accountability mechanisms that are in place to make sure that the service provided by relatives really are given? And how does the system deal if there is a situation of abuse from relatives that are caregivers?
Well, domestic abuse is a problem. But when we were planning cashing counseling, we talked to a lot of domestic abuse experts, and they said, well, we actually think it's going to be less of a problem in your program, because if somebody is doing this kind of thing, they want to do it sort of in the darkness, so to speak. Why would they want their name? Why would they want a counselor to know who they are? Why would they want, uh, the accounting service? And, there just would be more attention paid to them. And so, because you can steal grandma's social security check as an unpaid caregiver, and neglect and abuse them. So they didn't think it was going to be more of a problem. In fact, they thought it would be less, because there would be at least some oversight. The other thing that I think is another issue is that when you're hiring family members, friends, and neighbors, they're all part of the same social circle. So you have a lot of eyes on the person, and those other people are going to see if they're not getting the services. We tend to put too much emphasis on the idea that, say, a case manager or somebody is going to be overseeing this. But the case managers have huge caseloads, and they spend a lot of their time, doing assessments and, doing things. And you're lucky if they check in with you once a month. I mean, I had people saying cynical things to me. It's like, I always know that I'm going to get a phone call at the very last 2 days of the month, because if the case manager doesn't call me, she won't be able to bill. And, so a lot of their oversight is going to be via telephone. They may only see the person once or twice a year. Now, the other thing is, if you talk to the counselors, and this is probably true of case managers too, they will tell you that 90% of the people need very little from them, and 10% of the people are their problem children, so to speak. Not necessarily that they're being abused or neglected, but I'll just have one little anecdote that was so funny. In Arkansas, one of the counselors, she used to talk about this woman out in rural Arkansas who was, they called her auntie. And she was an elderly spinster, very, very religious. And she did not believe that women should wear pants. And the counselor used to keep a skirt in the trunk of her car, but she would stop at the filling station and change into the skirt every time she was going to go visit auntie. But she said the biggest problem with auntie was she would hire aides, and she didn't have family members to hire. So she would hire people, and they were usually young women, and they didn't want to be bossed around and told that they didn't have the right to wear pants. And so she went through a lot of workers. And, who was abusing whom in this situation? I don't know. It wasn't abuse, but, so you can have those kinds of problems going on too.
Thanks for sharing. So we heard some elements that we believe have potential for implementation in the Latin American and Caribbean region, mostly the potential to improve the quality and continuity of care, while also empowering the persons with disabilities or with functional dependence, and also formalize the unpaid caregivers. In a few days, you will be able to access the recording of the presentation as well as the slides, both in English and Spanish, on the webpage of the Panorama of Aging and Long-Term Care. We will also select some of the questions that have not been answered and post some written answers. I would like to thank, first of all, Pamela for today's webinar. Thanks for joining us.
Thank you.
I would like to thank Beatrice Fabiani, Alex Chaverri, Narumi Akita, Angelica Mendes, Wagner Reck, Silvia Moron, and the KIC department for making this webinar possible. And of course, thanks to all of you for joining us today. We look forward to seeing you in our next webinar.